Hey folks, Scott Weingart here, and this is the EMCrit podcast. Specifically, this is CV, cardiovascular EMCrit. But in a departure from our normal CV, this is actually CT-EMCrit, cardiothoracic EMCrit, because we're going to be discussing a thoracic topic today. Now, the reason this is a we and not a podcast is that I don't think this will be of particular interest for emergency medicine. And almost everything we put up on the show is really geared towards both emergency and critical care. This one is really just critical care. And so I made it a we, and I just want to warn you. Now, it's not to say it won't be incredibly interesting to emergency medicine. I was fascinated by it, even though I'm probably not at this point in my career going to do anything discussed in this show. But it will probably not affect your practice as a general emergency medicine practitioner versus emergency critical care or any of the intensivist fields. So you've been warned. Check it out. See if it's piquing your interest as we go. And if not, then I don't think there's any shame in bailing out. I did not do any thoracics. In my first round of fellowship, it was all surgical, critical care, and trauma. The second round, I went back specifically for cardiovascular critical care, but they had actually taken thoracics out to their own unit. So like Trina, almost all of my practice is cardiovascular at that stage, not thoracic. So this is a knowledge gap that needs to be filled, and I'm really happy that this particular area was checked off my mental checklist today. I have Trina Augustin, editor of CV-EMCrit, and Gabriel Ortiz about to start his career as an interventional pulmonologist. He's done Pulm Crit fellowship and then an interventional secondary fellowship, and now he's going to be starting as Mayo as an interventional pulmonologist. And he is brilliant. Trina is always brilliant, so I think you're really going to love the show. Let's roll right in. We are back for another episode of cardiovascular EMCrit, though this time it's branching out. This is cardiothoracic EMCrit. And as always, we're back with the editor of this section, Trina Augustin. Trina, say hello and remind people what you do in case this is their first time.
Scott, it's wonderful being back on the podcast. For most of my listeners, you guys know I'm a cardiovascular intensivist, and I do a little bit of time in the emergency department as well. So it's lovely being back.
Absolutely. And we're lucky to be joined by a guest, Gabriel Ortiz. Gabriel, tell people who you are and what you do.
Gabriel Ortiz. I am finishing my interventional pulmonology fellowship at the Mayo Clinic.
Yeah, so you've done Pulm Crit, you finished that fellowship, you did interventional as well, and now you're going to be, I hear, practicing at the Mayo?
Yes, I'm staying as staff and thrilled about it, yes.
All right, I love it. We're going to be discussing a topic today of persistent air leak. So why don't one of you give us an introduction to persistent air leak?
Gabriel, why don't you go ahead and lead us off?
The easy way to see it is persistent air leak is the clinical manifestation of particularly two different entities. And as the name implies, it's an air leak observed through a chest tube drainage system that extends beyond a set amount of time, which is still controversial. And I think that the first point to talk about is the duration, which we'll probably touch on. But usually persistent air leak is what we can see at the bedside, and it can be the manifestation of a bronchopleural fistula, which is a communication between the pleural space and the proximal airways. Usually arbitrarily defined as the airways that can be bronchoscopically accessed, or it can be the manifestation of a alveolar fistula, which is a persistent visceral pleural injury that allows air to pass from the alveolar units into the pleural space.
So what is the time cutoff for where if the patient continues to have air leak, we'd say they now have persistent air leak?
So there's no universal definition of a persistent air leak. And it stems from the fact that air leaks can go on for a few days and still resolve spontaneously, and we'll touch on that probably later. Some more aggressive guidelines and the previous guidelines from the 2010s usually drew the line around the third day, right? An air leak that persists for past the third day would be considered to be persistent. Nowadays, and the more modern guidelines have a time frame of about 3 to 7 days. So it's not a black and white definition, unfortunately, but we can say that an air leak that persists beyond day 3 to 7, so around day 5, could be considered a persistent air leak. And it's important to make that distinction, because when you call something a name, when you're giving it a pathological name, then you're prompting therapies. And as we'll talk about probably down the line, sometimes one of the best therapies is just waiting. So that's why the definition is a little gray in that regard.
And now, if you had a patient who had a massive air leak despite chest tube drainage on day 1, could you be safe in saying this patient has a bronchopleural fistula at that point?
It depends on the scenario. And it's right. If you have a patient that has a high volume air leak early on, those patients have a much higher risk of progressing to persistent air leaks. And we know that because there are studies being made with devices that actually quantify the flow of the air leak. In the surgical scenario, when you have a patient post lung resection, particularly, whether it's a lobectomy, pneumonectomy, or a non anatomical resection, that has a rib roaring air leak on day 1, you can suspect a proximal airway problem, right? So that could be problem with the closure of the bronchial stump, or the early dehiscence, or those problems that are feared by thoracic surgeons.
All right, so just quick terminology review here to make sure we're all on the same page. A bronchopleural fistula is communication from the airways proximal to the subsegmental level. Basically, anything you can reach with a bronch, if the fistula is there, then it is a bronchopleural fistula. If it is below that to the airways you cannot reach with a bronch, then it is an alveolopleural fistula, an APF. And then we're talking about air leaks. And when air leaks become persistent is after some arbitrary period of time. It varies depending on the source. Some of the older sources would say after 48 hours, it's a persistent air leak. Currently, it's a range somewhere between 3 and 7 days, with I think 5 days being the magic number of goodness in your mind. So an air leak that continues past 5 days becomes a persistent air leak. And that's what we're going to be talking about primarily today. All right, let's get back. Now, you had mentioned just a second ago actually quantifying this. So it's not enough to know that it's there. We actually want to know how large this persistent air leak is. So there's a couple of different options here. What are you folks using at Mayo to quantify?
Even at Mayo, we use probably most commonly what it's being used at every other hospital in the world, which is quantifying the flow of bubbles across the water seal trough. And it depends on the brand of the 3 chamber collection systems you use, whether it's an Atrium or a Pleurovac. They all come with a way of distinguishing higher flow fistulas. For example, the most common is by columns, right? So the more columns the bubbles are able to reach in a horizontal distance, that means that you have a higher flow fistula. There's more sophisticated systems, particularly there's one commercially available called the Medela system by Topaz, which quantifies airflow in milliliters per minute. And there's a couple of studies showing that high leak volumes, probably higher than 100 milliliters per minute, are less likely to resolve spontaneously and to require intervention, most prominently in the surgical world.
And I've never seen one of these. I guess my hospitals aren't rich enough to buy these digital systems for chest tube drainage. So I've always used the columns. Tell me how this relates to the phases of ventilation.
What you're alluding to is probably the Cerfolio classification of air leaks. And Dr. Cerfolio is a thoracic surgeon. I think his career took him to Alabama, but he was at some time at Mayo. And he graded it depending on the respiratory phase where the air leak was present. And of course, the milder end of the spectrum is that air leak that is only present in forced exhalation or coughing, which means that you really need a significantly positive intraalveolar pressure or intra-airway pressure to elicit the leak. Whereas when you have a leak that is present only in inspiration or a leak that is continuous, those are more severe. And Dr. Cerfolio actually has authored most of the studies in terms of management in the surgical world. And they were able to correlate how severe the fistula was in terms of the Cerfolio classification with the likelihood of resolving, and also how aggressive the surgical approach needed to be in terms of taking the patient back to the OR earlier than later.
All right. So now we've discussed alveolar or broncho pleural fistulas as a etiology for persistent air leaks. We've discussed quantification of the air leak itself. Where are the etiologies for this persistent air leak? And I think you could break this down into medical and surgical. Tell me about this, Gabriel. What causes these?
I think that's the simplest and the most patient-centered way to classify them in terms of surgical and medical. Of course, surgical, anything that opens the pleural space will be at risk of having a persistent air leak, particularly, and of course, most of the literature is on lung resection, right? And those are the patients that are the highest risk, particularly and historically, the patients that were undergoing lung volume resection surgery for emphysema. Those patients really got very extensive bilateral upper lobe lobectomies with very long staple lines that sometimes were not automated staple lines when they started to do that. And those patients, nearly half of them ended up with a persistent air leak. But any lung resection surgery is at risk in anything that opens the pleural space. For example, Dr. Augustine's patients that get a sternotomy and the pleural spaces are open to harvest a Lima graft, or for whatever reason, they are at risk of having unnoticed small visceral pleural injuries that could end up in that category. In the medical patients, of course, any etiology for pneumothorax, with, of course, the highest risk are the secondary spontaneous pneumothorax patients, which are those that have very sick and very ill lungs that have very bad alveolar surfaces. And when they have a pneumothorax, it's much harder for the lung to heal that visceral pleural injury. Whereas if you have a pneumothorax after a central line, it would be very hard for that visceral pleural injury to not heal properly.
All right. So now we're going to move to management. And you folks have put in the post a beautiful pathway, which is drain, wait, watch, and then escalate. And that alludes to the fact that many of these, if you watch them, will get better. So let's first talk about chest tubes. And what I find now is post-operative, they come to the CV-ICU, they're usually going to have nice large chest tubes placed intraoperatively. But we've moved in the medical world to tiny 14 French pigtails for almost every patient with pneumothorax. Is that going to be a problem for these patients?
There's very strong evidence in favor of small or percutaneous or pigtail drains. In this scenario, multiple systematic reviews were citing one of the most important in the aisle. However, there's one caveat that we always have to keep in mind. If we think that the patient has a higher risk, if we're facing a patient with pneumothorax and we think that patient has a higher risk of progressing to a persistent air leak, then when we're placing the chest tube or the drain, we always wonder, at least we do, whether we think that patient is going to need any type of pleurodizing agent. Because if that's the case, then probably you would try to go towards the kind of larger spectrum of pigtail drains. Our particular practice is we tend not to do talc or blood patch pleurodesis through anything smaller than a 12 French, because a 10 French could easily clog. And the problem is that some of these patients were actually doing the pleurodesis because they cannot tolerate being off suction. So if you have a small drain that you clog with your pleurodesis, then that can be a tension pneumothorax waiting to happen. So that's the caveat there.
If I can interject
please,
here, I
Gina.
think for the most part, so I will tell you, Scott, that my incredible colleagues, Gabriel included, they might put in a little smaller. To me, a small bore chest tube, that tends to be my Wayne pneumothorax kit with a 14 French, which is my go-to. They expertly have patients that they're putting in a little smaller French, which you can hear that he's alluding to. But I think all of us are trying to steer away from the large surgical chest tubes because I think the data is really supportive. I think there's those rare situations where you have patients on continuous positive pressure or you have a really high volume leak. You might have a really large proximal bronchopleural fistula. And some of those patients may require either a couple small bore tubes or they might actually need a large bore tube, especially if they have to be on continuous positive pressure ventilation with fairly high mean airway pressures and you have this big leak. So those are people just to keep in mind.
Yeah, that's fantastic. And actually, I had a question I wanted to add to that because in the trauma world, we would sometimes have patients who had a traumatic bronchopleural fistula. And they would have reasonable sized chest tubes placed. At that point, they were usually getting 32s, 28s. Like we're talking big chest tubes. And when I was a fellow and the air leak was actually overwhelming the ability of that chest tube to drain, my question was always, should I turn up the suction? And my attendings always said, no, in that circumstance, just place a second large chest tube. What's your feeling on this? Air leak so large that it's actually causing hemodynamic consequence from tension physiology despite a functional chest tube. What are your go-to moves?
I guess the way we approach that is based on the size of the defect that we think we're dealing with, right? As you mentioned, if you have a patient with a main stem bronchial disruption or a tracheal disruption or something that really has a very large defect causing a major proximal fistula, then of course you will need progressively higher drains to be able to keep up with the leak. Here, the goal is to make sure you have a good balance between preventing tension and maintaining the fistula flow, right? As Dr. Augustine is going to probably touch on about the physiology. The idea here is to try to slow down the flow across the fistula with, on the other hand, preventing tension. So that's the balance, right? If you have a patient that is in front of you progressing to tension, even if you have a large drain, then the first thing to save the patient is probably put the patient on suction and wonder if you need another drain. Sometimes we end up placing multiple drains for patients with large pneumothoraces that we are unable to keep up with or that are loculated. That's the other caveat. However, whenever you're placing the patient on suction, you are, for that period of time, increasing the flow across the fistula and decreasing the likelihood of the fistula healing. So it's that balance. And then probably we'll talk about the evidence of suction versus no suction. But if you have a patient that is progressing to tension and is unable to tolerate water seal because of progression to tension, then that's when you have to put patient on suction or escalate to another drain.
That's fantastic. Trina, do you ever find yourself raising the suction level above 20 we're moving so much now to getting them off suction entirely, but are you ever finding yourself having to go above our standard initial setting?
No, almost never. I find that -20 tends to do the job for me for the most part. And if I'm needing more suction than that, then I'm tending to favor going for my next chest tube because I am trying to move away from suction on these, as we'll talk about more and more. Clearly, in the acute setting, you first save the patient's life. You deal with tension physiology, and then you move towards long-term healing. I think Gabriel put it beautifully. But yes, typically not more than -20 when I'm on.
There is one condition where we would use higher suction, and that's right after we do pleurodesis. If we have a lung that is relatively collapsed and we're trying to pleurodese to come off suction or guarantee that there's going to be adhesion between the two, the visceral and the parietal pleural surfaces, right after we do talc or right after we do blood patch, we try to keep the lung up and against the parietal pleura. But that's a very kind of unique situation, as Dr. Augustine says, that probably that's one of the only situations where we would go higher.
That's fantastic. All right. We had spoken earlier that before intervening, you should give the patient some time. And so how long do you wait, Gabriel?
That is a very important question and unfortunately one universal answer. And I think we cited the most important study in that regard where they compare or where they followed patients without intervention in the setting of secondary spontaneous pneumothorax, which is a very high risk scenario. And if you wait up to 2 weeks, almost 80% of the air leaks are going to be gone without an intervention. However, of course, you have to balance that with hospital stay and then critical illness, the risk of infection, the risk of respiratory deterioration. So the guidelines initially have veered towards intervening when you have more than 48 hours, as we had discussed. But right now, probably that sweet spot may be between the 5 to 7 days in terms of when to intervene with advanced therapies. And those advanced therapies are beyond just draining and balancing suction, no suction, right? That's the basic management. And then when you're past the 5th to 7th day, which is what the European guidelines from last year are saying, then that's when you try to think about other alternatives.
Now, you guys had mentioned this earlier. Now, this is the spot we have to really hit it. There's been, I think, a sea change in the idea that as long as there's air leaking, they must be on suction. That's what I was taught 25 years ago. And now I think we're in a different place. And in fact, some of the emerging literature from trauma says you could just water seal them as soon as you get your initial drainage of air out. What is the current thinking on suction versus water seal for these patients who are having air leak?
Yeah, as you're saying, that's absolutely right. The shift has been towards early transition to water seal if the patient can tolerate it. And again, the key or the hinge point in the management of these patients is whether they can tolerate being on water seal or not. If your patient doesn't progress to a tension or emphysema or clinical worsening without suction, then going to water seal as early as possible is the trend. And that stems from actually the surgical literature. And this is actually where Dr. Serfolio actually employed his classification the first time, where they randomized post-resection patients, which were higher risk, to be on water seal on day 2 versus just keeping the suction for longer. And those patients resolved their leaks earlier and had better kind of hospital outcomes and lengths of stay. And that has been vetted in the surgical literature particularly, but also in the medical world, particularly the spontaneous pneumothorax literature. That's the trend. If the patient is able to transition off suction or tolerates being off suction, an earlier transition to water seal is favored because at least you know that you can transition that patient to a Heimlich valve if anything else fails.
Yeah, it's funny. That was the next question is if you're not going to have them on suction, then the idea of sending them home becomes a possibility. Though I got to say, this kind of scares me a little bit. If I know they have a persistent air leak and if they just kink that tube, we're going to have some problems. So how many of these patients are you sending home to come back and recheck if they're a persistent air leak?
We have quite a population of patients, particularly these patients that have secondary spontaneous pneumothoraces from very bad emphysema or patients that had lung radiation injury for lung cancer that developed these air leaks. And we do have a fair amount of those patients that we do everything that we're going to talk about next to try to get them off suction so we can send them home on a Heimlich valve. And we do have a Pleural clinic that sees these patients all the time, every day.
That's super cool. All right, we're in the next step of escalating here. We've done our watchful waiting for 5 to 7 days in most patients, and now we're saying they're just not actually stopping the leak. So what is first up on our management escalation pathway?
If we go by the guidelines, there's only one strategy that has the enough evidence so the experts agree on recommending it, and that probably is the most used form of pleurodesis in these scenarios, which is blood patch pleurodesis, or the orthodox name of autologous blood patch pleurodesis. That would be the first line of treatment for those patients. And it's just what it sounds like. It's just having a phlebotomy of between 1 to 3 milliliters per kilogram. And what we do is we need to make sure, and that's the most important first step, is make sure that the patient can tolerate being off suction. If the patient can tolerate being off suction, then we instill that volume of blood through the chest tube and we hang the chest tube at phlebistotic height. It's variable between 30 minutes and 2 hours, ideally. If the tube can be clamped, then we clamp it. There's not all patients can tolerate a clamping trial of that length, but the kind of textbook would be to clamp the chest tube for at least 30 minutes and then open it. If the patient cannot tolerate clamping because they progress to tension, then you can hang the draining system at phlebistotic height.
Now, pleurodesis is something outside of my comfort area. I never really did the medical ICU side of it. So I just have a real outsider's understanding of this. Tell me from a physiologic perspective. It seems like the lung being able to slide was built into our original conceptualization. Is it a problem to have a lung locked to the parietal pleura? Do the patients experience any respiratory mechanic changes from this?
I can tell you it can be a blessing sometimes for these patients when we're able to pleurodese them. So pleurodesis, as you're saying, is trying to achieve the adhesion of the...
Hey folks, but you know we're not getting right to the show because You're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Visceral and the parietal pleura. In the case of blood patch pleurodesis also, we are trying to form a clot in the area of the visceral pleural injury, and that can seal the leak, at least transiently, while the pleural surface can heal. Pleurodesis can be a problem, and can be a problem in two ways. Blood patch pleurodesis can have a slightly higher risk of infection, but not too high. But it can be a problem in two ways. Patients that have a very significant respiratory compromise when they pleurodese can get a little worse, number one. And number two, in some of these patients where we have considerations for lung transplantation down the line, or any type of surgical reintervention, then intervening a pleurodesed pleural space, it's very challenging for the thoracic surgeon. So much that in the past, it was thought to be an absolute contraindication for lung transplantation down the line. And these are patients with parenchymal lung disease, emphysema, and all of that may need lung transplantation down the line. That has been reevaluated. And there are populations where it's clear that even after pleurodesis, they can undergo lung transplantation, particularly in things like lymphangioliomatosis and these cystic lung diseases. So they can get worse. However, if the issue that physiologically affects the patients the most is then persistent air leak, then trying to seal it by pleurodesing is helpful. The other clinical scenario where pleurodesis can be a blessing and it's outside of the scope of this review is a malignant pleural effusion, of course, where we're trying to obliterate the space, preventing the effusion from coming back.
All right. So pleurodesis is an option if the patient could tolerate being off continuous drainage for that period of time. What about surgical options? What about sending these patients for VATS and just directly repairing the parenchymal injury and, for instance, an alveolar persistent air leak? When does this come online?
It should come online early if the patient is a surgical patient, particularly if it's a post-resection patient that has a very early leak. First 14 days is the classic teaching. Another scenario where Mayo has made some contributions with the creation of temporary windows and things like that. But in general, an earlier fistula should be intervened earlier because you want to prevent also contamination of the pleural space. If you leave proximal bronchopleural fistula for long enough, it's going to become a very hard to treat empyema. So if the patient is surgical, if you think it's a very large bronchopleural fistula, then that is more towards the surgical side of things. And there's multiple interventions that can be made. And those interventions after lung resection are aimed at reinforcing the stump, right? So they can repair the stump. They can resect more proximally the stump and redo the stump. They can use omental or intercostal muscle flaps to reinforce the stump. And those are surgical alternatives for that. In medical patients or other surgical patients, the surgical intervention that can be performed is a surgical pleurodesis, where what they do is they scrape off the parietal pleura off chest wall and allow that inflammation to seal off the space. That I would say could be common for patients that have a surgical fistula that is not from the proximal airway, but it would be uncommon for medical patients.
All right, let's go to your real area of the things you salivate over, Gabriel, which is bronchoscopic management of persistent air leak. Tell me about this.
Very enthralling topic, and it's become probably one of the mainstays of treatment for these patients that wouldn't have other options otherwise. But in general, I think bronchoscopy can be helpful in terms of diagnosis and to some degree in terms of treatment. So diagnosis would be important if you think that it's important to localize the fistula. in terms of treatment or in terms of other kind of treatment pathways. So the first step we always, when we have these persistent air leaks that we have done pleurodesis on and they don't stop, then we go ahead and leave these patients for bronchoscopy. And the first thing we try to do is to locate the proximal airways leading to the fistula or to the leak, number one. Or number two, rule out that we're not dealing with a proximal bronchopleural fistula, right? If we're doing a bronchoscopy and we see a large defect in a mainstem bronchus, then the diagnosis is made, and then we have to use a different armamentarium of therapies to try to occlude those big leaks. If we're dealing with a more distal alveolo-pleural fistula or a distal bronchopleural fistula, what we want to do is try to localize the airways, the segmental airways leading up to them. And we do that with very simple maneuvers, such as inflating a balloon in each segment and observing the air leak. Or we can also use dye localization, where we instill usually methylene blue through the chest drain and we observe which segmental airway brings on the dye first. And that's the first step, which is bronchoscopic localization.
If you localize the leak, then the possibility of a one-way endobronchial valve becomes an option. And I have no experience with these. Tell me a little bit about that, Gabriel.
So when you have an alveolo-pleural fistula or a distal fistula coming from the smaller airways or the parenchyma, where you really cannot intervene proximally, then what we do is we use these one-way endobronchial valves, which we have two commercially available valves. In Europe, they have coils, and in Japan, they have little plastic plugs. And what we do is we try to place those valves in those areas where we think the fistula is coming from, which is almost always harder to do. And almost always, these fistulas don't come from a single segment, so we have to block multiple segments. And these valves are either umbrella shaped or bird beak shaped, and they are one-way valves. So they are going to collapse and cause atelectasis of that distal area, prevent further leak from going across the pleural surface, and by collapsing that area will allow for a better pleural healing. That's in the setting of an alveolo-pleural fistula. There's two systems. One is called the spiration system. That system particularly has an humanitarian approval by the FDA for persistent air leaks since 2008. So that's our first line. They were approved specifically for post-surgical fistulae or post-surgical persistent air leaks, but they've been used for secondary spontaneous pneumothorax, and there's randomized clinical trials on them. So that's one of the most commonly applied treatments we use. We also use them for distal surgical air leaks. Now, if the leak is coming from a proximal bronchopleural fistula or something in the more proximal airways, then that's when we have to employ other strategies, because we would have issues with blocking off an entire mainstem, or we don't have a large enough valve to block a big segmental airway or a big mainstem airway.
That makes complete sense. And you guys at Mayo are going to some of the more esoteric therapies, trying to actually repair defects or using actual a septal occluder, all sorts of crazy stuff that are discussed in the blog post, and we'll go in depth there. But suffice it to say, you guys have tricks in your bag for these patients.
Yeah.
And
if you can see the hole, you can use very unorthodox approaches, I would say. And they've been used for a long time. Yeah.
All right. So now, if we have to escalate further, we get to where Trina has been patiently waiting and salivating to discuss, and that is the management of these patients on the ventilator, because that's obviously going to make this more difficult if the patient's on positive pressure ventilation. So we'll discuss that. We'll discuss a little bit about what vent mode and settings you actually should go. But then if that's still failing, then we get to Trina's true love, VV ECMO. So Trina, why don't you start us off telling us how to deal with these patients when they're on positive pressure ventilation?
Awesome. This topic is near and dear to my heart. And what's interesting is, as you rightly pointed out at the beginning of this podcast, I'm a cardiovascular intensivist. So reaching into the thoracic world was not something that's truly normal for me. But these patients have really come on my radar thanks to our incredible interventional pulmonology colleagues, one of which is Gabriel, when we start collaborating on the sickest of the sick of these. I think first and foremost, and we've alluded to this already, the goal with these patients is if you can keep them off of positive pressure ventilation, that is by far the goal. You really want to stay away from having elevated mean airway pressures and elevated transpulmonary pressure, and we'll get into that in just a minute. But truly, if you have a patient that has adequate oxygenation and ventilation and doesn't have a significant increased work of breathing, if you can just keep them breathing off of positive pressure, that should be the first go-to.
And now, if you had the opportunity to, maybe they're borderline, but you're like, I'll try it for a while, it would be keeping them on high flow a better strategy than intubating them?
There are times when we would try high flow because really, as you and I both know, you're really not getting much of any positive pressure through that. And sometimes that can really help with a little bit of dead space washout and help these patients with their air hunger feeling. So that's something I was willing to try before.
All right, that makes sense. But let's say the patient's actually on the vent, they have persistent air leak, or even before that point, because it's still relevant. It's only day 2, but they have air leak, and so we won't call it persistent yet, but they have air leaks. What's causing our problems, and how do we make it better on the vent, Trina?
I love it. So let's talk first about what's causing the problem so we understand how we can fix the problem. So truly, these air leaks thrive on high mean airway pressures and high transpulmonary pressures. And if you think about that, if you are increasing that pressure inside your alveolar space, you really are going to increase that flow across that fistulous connection if you have one. So the thing I always say is that transpulmonary pressure is the enemy here. And so I think it's important that we clarify what that is. Now, there's older definitions and there's newer definitions, but I like to simplify it. I like to think of transpulmonary pressure as that distending force across the lungs. And specifically, think of it as your alveolar pressure minus your pleural space pressure. So basically, it's that pressure gradient that's driving that pressure across that fistula. And if you like to think of it in Ohm's law, you can think of flow across the fistula being equal to your transpulmonary pressure over the resistance in the fistula. As you and I know, unless you're doing fancy techniques like Gabriel's doing, we're not really adjusting the resistance of that fistula. If it's a wide-based fistula and has low resistance, we're just stuck with that. But what we can control is that transpulmonary pressure. And so there's many things that we should be thinking about when we manage our vent. So we want to do everything we can to decrease our airway pressures and also to decrease that pleural pressure. So when I start thinking about the vent on these patients, if I absolutely need to get there, and those tend to be the patients that have maybe your bigger bronchopleural fistula, they might have had spillage, and at this point they have ARDS, they have a bad pneumonia, but for some reason their oxygenation ventilation isn't great. And so you end up on positive pressure ventilation. The big thing that I'm trying to do is decrease my tidal volume, my PEEP, my driving pressure, my inspiratory time, and even my respiratory rate. And you might say, that's like everything. How are you maintaining adequate oxygenation and ventilation? And I'd say that's where the challenge comes, because these patients can be really challenging to maintain adequate gas exchange while keeping your mean airway pressures and your transpulmonary pressures low enough. And so on the sickest subset, that's where we're going to talk about VV-ECMO. On the not so sick subset, you have tricks, and you can allow permissive hypercarbia. If it's one lung that's not working well, you can decide to try to do single lung ventilation. You can do double lumen endotracheal tube, drop an endobronchial blocker. But there is a certain point where you sometimes get to on these patients where you're saying, you know what, I have minimized my settings as much as I can. And despite that, I have this persistent air leak and I'm just not getting anywhere. And then the question becomes, do I need to do more interventions like we've just talked about? Or do I need to be able to be more ultra lung protective? And that's where sometimes VV-ECMO can come in and really be a star, not just as a rescue therapy, but as a strategic tool to help optimize the healing conditions for your lungs.
You know, Trina, as you were talking, and don't worry, I'm not going to block you too hard to go to VV-ECMO immediately here. We'll get there in that discussion. But you mentioned that we can't really increase the resistance of that fistula. But what occurred to me, and I know like I'm just hitting with you with this, we haven't mentioned this question beforehand, but we probably could increase the pressure in that fistula. And I'm just thinking like we could rig up like a PEEP valve type system pretty easily that would increase the pressure in that actual pleural space. Has anyone given any thought to that? Because that would decrease the flow across the fistula, the transpulmonary pressure.
So I'm laughing because Dr. Lewis McLean, so one of my fantastic reviewers that works with me, and I briefly were emailing about strategies that were used like historically, where they would actually put like positive pressure inside the pleural space. And if you think about it, if you're putting positive pressure in there, you can help to equalize the pressure in your pleural space and in your lung. And hence, if you don't have a delta pressure change, you're going to decrease flow across that fistula. So clearly, things like that have been tried, and there is some data out there with some success. Now, in a more modern practice, I haven't seen that done and I haven't physically done, so I can't speak to its effectiveness, but conceptually, it makes sense.
All right. So now the patient is still maintaining that persistent air leak despite trying to go super low, super slow on our vent settings. And we've tried all of our other maneuvers. And now we come to you and say, Trina, help us. We can't make this work. How do we make this work?
Typically, and I always joke that I get to cheat. So sometimes I can get pretty lazy with my lung mechanics, and I try not to. I try to, first and foremost, remember that I am an intensivist by training and that I should optimize the vent all the time. But yes, I do have VV ECMO in my toolbox. And the beautiful thing about VV ECMO is that I can really allow myself to decrease mean airway pressure and transpulmonary pressure to levels that would otherwise absolutely not be possible. In fact, we're talking sometimes going as low to almost PEEP of 0 or PEEP of 2 to 3. Driving pressures, they'll even have in literature as low as 1. And many of us will actually just take them off of positive pressure ventilation altogether once we have them fully supported by VV ECMO. Now, one thing, Scott, I realize that you and I have talked a lot about gas exchange on VA ECMO. We've had a whole podcast on how with peripheral VA ECMO, you end up with these crazy dual circulation physiology, and you end up with the ECMO circuit and the patient's native heart and lungs. It's like these two circuits in series. And really there, you still have to, while you're doing lung protective ventilation, you still need to use the patient's native lungs. The beautiful thing about VV ECMO, and we're not going to get into all of the gas exchange things because I could talk a whole 50-minute session on that, and I could. But the beautiful thing about VV ECMO is that at this point, we have two circuits in series. And what do I mean by that? Just for the listeners who don't think about this as much, I typically am placing a large, like 25 French drainage cannula, typically in a common femoral vein, and it's going to end somewhere around that IVC-RA junction. Now, whether you do FEM or FEM-IJ, which are the more typical configurations for VV ECMO, say you have a return in the right IJ and you return that blood to the superior vena cava. The big thing to think about is, yes, you're draining all that blood, you're returning it, but that blood is mixing with the patient's native flow that is going through their heart and lungs. So basically, you have one homogeneous blood flow that's coming out through your aorta, and the whole body is seeing that same gas exchange. And if you put big enough cannulas in, you're able to actually flow fairly high, sometimes as high as 6 liters. And so you can catch a significant part of their cardiac output and actually do the lion's share of gas exchange. So you truly can put these patients on ultra lung protective ventilatory settings. And even I talk in this post about being ultra lung protective, where really my ECMO machine is doing basically all the work. Sometimes these patients have tidal volumes of 20 to 30 cc's. So really, their own lungs aren't doing a lot of ventilation. It's more my circuit doing carbon dioxide removal and oxygenation.
Absolutely. Now, how long, if you've made this decision to put the patients on VV ECMO for persistent air leak, how long do they typically need the ECMO run for? And then what do you do at the end of that?
Yeah, so I'm laughing because this can be some long runs, and Gabriel knows this as well because we have collaborated, and patience is key here. For me, the typical progression is I get these patients, I put them on VV ECMO, I initially drop their settings right away. I'm talking driving pressures at least probably down to 5, PEEP of just very minimal, maybe 2 or 3, drop their respiratory rate really low. And typically when I get these patients, they've been like, sometimes they're paralyzed and sedated because they were at extremis, not at a great spot. So after I have minimized their mean airway pressure, their transpulmonary pressure, then I try to get them woke up. Because then my goal is, can I optimize my ECMO setting? So go up on the sweep gas. Can I decrease their work of breathing, their respiratory drive, and get them awake? If I can get them awake, get them off of sedation, then I'm starting to evaluate them. Are they going to protect their airway? How's their work of breathing? Is this a patient that I can actually just extubate, get off of positive pressure altogether, and completely support them? Some patients I absolutely can, and that would be key because, as you're alluding to, especially patients with necrotizing pneumonias and some of these other things, we might be talking weeks of a run and sometimes even longer. And so having them up doing rehab and all of that, that is by far ideal. I don't have to go into why we want people off of ventilators. We all know there's tons of benefits with reduced delirium, sedation requirements, pneumonia, all of these things. On the patients that I am unable to extubate, if it's an airway protection thing, that's an easier one. I tend to just move towards early tracheostomy. And then my goal is, as soon as I can, get them to trach collar or maybe even just high flow if that makes them feel better through the trach. So here again, minimize mean airway pressure, minimize transpulmonary pressures. Now, there's that challenging subset that we also saw in COVID that no matter how high I titrate my sweep, and I specifically like to talk about this because I find that people so often are so fixated with gases. And so what they want to do is they just want to titrate their sweep to a perfect gas. On these patients, I sometimes will allow them to be a little bit more alkalotic. In fact, my goal is to decrease their respiratory drive, have their chemoreceptors see a more alkalotic pH, a lower CO2, and see if I can actually decrease their respiratory drive. There are some patients with ARDS, with delirium. My theory is maybe such severe lung injury that maybe it's their C fibers in their lung. There's something that's causing them to breathe hard and deep. And those patients are the ones that worry me to take them off the ventilator and sedation, because you have to take into account patients' work of breathing. Because you and I both seen those patients that are taking those massive breaths. They can really create significant negative intrapleural pressure, which is massively increasing that transpulmonary pressure, and hence will increase the flow across that fistula. So you do need to take all of those things into account. But back to your original question of how long, I prep myself for weeks. Sometimes we're talking well greater than a month, and it's really important to prep your team. The same way that when I put their chest tubes on water seal, I prep the team, hey, you might see a pneumothorax, but as long as it is not causing tension physiology, that's okay. They stay on water seal. So it's the things that I think in medicine, the knee jerk is that we want to make every red box black and make everything look perfect. That sometimes can be harmful. Truly, in situations like this, you want to do what is best for the patient. And sometimes that's just sitting on your hands and watching and waiting.
Yeah, that's fantastic. And it does bring to mind a question, which is, you guys are working at an ivory tower built on top of other ivory towers. Most of the people listening are just general intensivists. If they had a persistent air leak, at what point should they consider transferring to somewhere like Mayo? And do you take these patients regularly?
So I think that's a great question. Interestingly, as being one of the cardiovascular intensivists, I'm not the front line for these unless they're so severe that they are unable to oxygenate and ventilate. And then, yes, I get the call on my ECMO line. But I think the important thing, if you are practicing at a center that doesn't have all these interventions, is you can do the first line things. You can place the chest tube. You can try to transition them to water seal. You can do the watch and wait. Now, whether you can do additional therapies from there, that will depend on your institution and also will influence when you would consider transferring. Because potentially if you have that patient that you put the chest tube in, you water sealed, but maybe you don't have the ability to do pleurodesis there or bronchoscopic interventions, then, as Gabriel alluded to, you might want to start think about transferring at that 5 to 7 day mark, kind of where we talked about it's time to start thinking about the next intervention. Now, clearly, this is always a shared decision making with the patient, because there are patients that maybe if you just give them more time, this will resolve. And so you might say, we're going to sit on it for 2 weeks and see, realizing that comes with the downside of more hospital time. But also, transferring, you and I know, does not come without its disadvantages. You're moved further away from family and loved ones. Every transfer comes with its share of risks. So those are things to consider.
Gabriel, I'm curious to hear your opinion on this as well. Sometimes I'd rather just take the patient earlier and just be able to deal with a patient before they've gone down the sequela of what might be sometimes less than ideal versions of what I could do at my own center. What's your feelings on this, Gabriel? They call you up and they're like, it's been 5 days. We have a persistent air leak. We're thinking about doing our own pleurodesis, or we're thinking about switching to your hospital. What would be your thoughts on this?
I think that, as Dr. Augustine was saying, we do get different flavors of that call, and we're usually the team that gets the call for persistent air leak. And I would say that determines how early you need to transfer the patient. One end of the spectrum is your patient with COPD or a pleural bleb that has a small chest tube and it's doing well on the hospital floor and not deteriorating, needing a little bit of suction or tolerating water seal. And then that would be probably the patient that I would offer a longer waiting time or some not so complex therapies. Then I would say in the middle, you have that patient that has very significant lung disease, right? Your severe emphysema patient, your post radiation therapy patient, your more advanced cystic lung disease, or that has a pneumothorax with a higher volume air leak. That patient probably needs an earlier consideration for other therapies. And many times, we actually just completed a review on this. More than 60% of these patients will require multimodal therapy and sometimes even repeated therapies. We have patients that we do 2-3 blood patches, 2 doses of talc, and then do valves on them. So those patients probably need an earlier referral, not crashing and burning, but need an earlier referral because they're going to need more therapies. And there's patients where we end up doing 6 valves and then we bring them back 6 weeks after, take them out, the leak comes back, and then we have to put valves again. And it's a little bit more complicated. And then at the other end of the spectrum is Dr. Augustine's call, where you have a patient with ARDS or with a rib roaring open post-pneumonectomy stump or a necrotizing pneumonia that with a very high volume leak, then that patient probably needs earlier referral so Dr. Augustine can stabilize, optimize ventilation, put them on ECMO, and then we can think about what to do afterwards. I would say it depends on the severity and how grave the situation is. If that's probably a judgment call, but I would say that's what I've seen my masters and teachers do.
All right, fantastic. What have we missed for either of you? What final thoughts do we want to add?
I think Gabriel's beautiful answer that he just gave you brought up a really good point of one of the other things that both his team and my team, I think, love about VV-ECMO is these patients are incredibly complex. And especially here at Mayo and at very many other quaternary care centers, we're doing incredible interventions. But oftentimes those interventions are really hard to do if the patient doesn't have some assistance with gas exchange. They have to try to otherwise do this intervention with limited oxygenation and ventilation, which can be challenging, even with like jet ventilation. So having these patients on VV-ECMO can really help to stabilize them and allow for peri-procedural support, which is really something to keep in mind with these patients. And so that's something that our teams have really collaborated on. And I think we've had some really incredible outcomes and saves that might have otherwise not been possible.
I was just going to bring up that exact same point that VV-ECMO may not only be the treatment to help reduce the fistula flow and improve healing, but it may be the only way in which we can do some of our interventions. And there's some fancy pictures on the post where we actually had to kind of resort to Dr. Augustine putting the patient on ECMO first so we can do a rigid bronchoscopy and put a proximal carinal stent. That on a severely ill patient with ARDS or like that patient, it's impossible to do if they're not on ECMO. So transprocedural and peri-procedural ECMO for advanced bronchoscopy is something that it can be life-saving. Yeah.
Yeah, I mean, it brings to mind to me the massive pulmonary embolism patient, where the thought of taking to interventional radiology this patient who is crashing on multiple pressors versus temporizing with a 24-hour run of VA ECMO and then letting them get that procedure safely and knowing they're not going to code, it's just such a vastly different patient outcome potential. And so I think this peri-procedural ECMO is going to gain more and more traction as we get better and better at it.
We've had to call Dr. Augustine in cases, even during the procedure, where we have to and put the patient on so we can get it done. So either we're bleeding or we're not oxygenating or we're leaking too much. Yeah.
Fantastic.
It's all about teamwork. Medicine is all about teamwork for the best outcomes for our patients.
You can't find a better spot to end than that. I can't thank you both enough. This has been wonderful and educational for me, not having a huge thoracic background. So I love this, and I think everyone else will as well. So thank you.
Thank you, Scott. It's been a pleasure being here.
Thank you very much. It's been my honor. Thank you.
Now, as comprehensive as this podcast has been, the blog post that goes along with it is even more complete. So you definitely need to check that out. That is what we tell you for all CV-EMCrit episodes. Do not tell us we missed something until you have read the entire blog post and seen the completion of the didactic experience that is CV-EMCrit. Hope you enjoyed this. Scott Weingart for the EMCrit podcast saying bye-bye.